All right. Thanks, Andrew, and thank you all for sticking around, and for those of you just joining us, thanks for coming. We have an excellent panel of healthcare experts here with us today. I'll just do some brief introductions. To my immediate left, we have the Honorable Richard Gottfried, the chair of the Assembly Health Committee. Second to my left is David Pomerantz, who's the Chief Operating Officer of the Hebrew Home in Riverdale. And then we have Dr. Hani Abdalal, who's the Chief Medical Officer of the Visiting Nurse Service of New York. Thank you guys for joining us today. So I wanted to kick off this discussion kind of touching on some of the issues of the moment. So at a certain point in last year's mayoral campaign, access to healthcare became a very hot topic, culminating in some high-profile protests against the closure of city hospitals, including Long Island College Hospital and Interfaith Medical Center in Brooklyn. Long Island College Hospital was recently thrown a lifeline by the state, saying that they could stay open, but shifting away from a full-service hospital with the potential for still accepting some long-term, having some long-term health care at the hospital, but I guess it wouldn't be as it is now. But I guess so. I wanted to start off the discussion by asking, with hospitals closing all across the city or shifting their delivery of services to different models, such as the one that Litch hopes to, can community healthcare centers or primary care clinics kind of fill that void? I mean, do they have the capacity to handle emergency room patients, for instance? And whoever wants to start it off, Assemblyman, if you want to take it.
Well, community health centers are not geared up to handle the things that you should be going to an emergency room for. And I say that because many people go to emergency rooms for things that people who have a family doctor would go to their family doctor for. If we had, all across the city, if we had much more primary care, whether it's private practitioner offices or community health centers, particularly in low and moderate income communities, then a lot of the care that is inappropriately done in emergency departments would be done in settings that are much more appropriate, much less expensive, and a lot better for the patient as an experience. Emergency departments that are not connected to an inpatient hospital are a fairly new concept to New York. I think it's an important and workable idea, and a lot of care that now rightly goes to emergency rooms could continue to go to emergency rooms that were not part of an inpatient facility. As I said, that's a fairly new concept in New York State, but I think it's one that clinically and financially ought to be doable. We've got a difficult situation with our hospitals, partly because modern medicine enables us to do on an ambulatory care basis a lot of things that used to have to be done on an inpatient basis, and that's going to be a difficult transition for hospitals, but one that I think is necessary.
I would just add that we're in the process of some pretty significant changes in the state related to managed care, where care will be less fragmented, and hopefully there'll be opportunities in different pieces along the continuum for somebody to manage that care more effectively, and ultimately result in less need for emergency care in hospitals. So I think that there's, as people are learning more about it, with mandatory assignment, with the rapid change that's going on, I think it's a period of time where people are sort of feeling out what's going to be and figure out the new way the design is going to fall. Because ultimately, when care ends up being in an emergency room when it doesn't need to be, it's expensive, and it's really not a good place for an older person or any person to be if they don't need to be for other reasons.
I'd have to agree. I mean, I think access is key. So access is number one. And being able to build up that access is what we really need to make sure that people have. But there's a huge transformation going on, whether it's the federal side or the state side. We're all looking to say, inappropriate admissions don't need to occur anymore. And whether it's managed care or accountable care organizations or health homes or any of the other things that we're testing out, all of that is about really getting people to the right providers at the right time and trying to avoid that. And then with the Affordable Care Act and getting, millions of people insurance, I think that's going to alleviate the fact and the pressures on the emergency rooms that maybe they will be able to use the primary care resources that we have.
Now, shifting gears a little bit, but still staying kind of close to this topic, the state was recently granted the $8 billion in the Medicaid waiver from the federal government. Mayor de Blasio has, I guess he said after receiving that that could be used to kind of find long-term solutions to deepen access to primary care, preventative care, and emergency care. I guess I'm curious, because we're focusing this panel on kind of the vulnerable populations in New York City, what long-term solutions are already being utilized to help augment that care for children and seniors specifically? I mean, David, you mentioned health homes, and you obviously have some experience in that area, if you wanted to maybe touch on that a little bit.
Yeah, as I alluded to before, there's a tremendous amount of change at play, and I think it's important as we have this discussion today to think about not only is that change complicated for us as providers or elected officials, it's extremely scary and confusing for vulnerable populations to try and figure it out. Literally the rules to some of these things, the programs, the access to these things has become a revolving door, a changing set of rules all the time, and I think it's important to pause and to realize how we can make it more understandable, more simplified for people to understand how they can utilize it and activate it so they can take better use of it.
I think one of the major policies that New York State has been going through, and care management for all under that phrase. And I'd use the example of myself trying to navigate or manipulate or get really the systems for us to figure out who the right doctor is and the specialist and getting appointments. It's not an easy task. So imagine that for the vulnerable population, whether it's seniors or young children or mothers, the advocacy that you need and the help in sort of navigating the system, I think that's the approach that the state has taken. And having care managers or care coordinators help the vulnerable population is key to figure out what needs to be done. So you or I or anyone else here will not know every specialty that's available, every clinic, every community resources. So having that person sort of advocate for you and be your representative, I think is key.
I think the notions that we're talking about here, care coordination, integration of care, are enormously important. We've all been hearing about networks that do this kind of care, whether it's the Mayo Clinic and its network, or Geisinger in Pennsylvania, several good models out west. New York is too slowly moving in that direction. What concerns me, though, is who is going to be in charge of the coordinating and the integrating. And so far, at least in the Medicaid area, when New York talks about care management for all, which is the sort of slogan of the state's Medicaid program, that's so far always been rooted in an insurance company. And I don't know about you, I'd rather that the organization that does my care coordinating and the integrating of my care be a more community-based and provider-based entity than an insurance company. There are states where, particularly in the Medicaid program, they do a terrific job of integrating and coordinating care without an insurance company as the middleman between the state Medicaid program and the people who take care of you. North Carolina has been doing that for a number of years. Oregon and Colorado are doing it. I think New York needs to learn from what those states are doing and get away from having insurance companies controlling our health care.
Now, I wanted to touch on the health homes a little bit. I guess one concern that I was reading about, I guess there was a case of AmeriCare in Queens where some were saying that they were denied home care because of changes in the state reimbursement formula that made caring for them unprofitable. Now, is this an isolated incident? Is this indicative of some of the challenges around health home agencies? And I guess, Dick, maybe you can answer this. Is there legislation on the state level that could help kind of regulate these?
I think you'll agree. I don't think we have enough time to answer that question in an intelligent way. But the state is trying to move home care and is moving home care, particularly for those who need it for more than a few months, into a managed care context primarily through special managed care entities called managed long-term care programs. There is a lot of concern that as home health care providers get hooked up with those managed care entities, they are going to get squeezed and pressured into dumping expensive cases or denying people as many hours a week of care as they used to be getting. Some of those fears are warranted, some are not. Like every transition that we've gone through as we move various populations and blocks of care into managed care, there's a lot of anxiety. There is often transitional turmoil. In other parts of the healthcare system, in Medicaid, that has worked out reasonably well. We're all trying to make sure that it works out reasonably well in home care and ultimately nursing home care as well. But it's going to take a lot of very careful monitoring and public oversight to make sure that people are well served and not hurt in that process.
Right. David,
Well, there's certainly mechanisms in place to determine appropriate levels of home care that sometimes become somewhat complicated. I mean, the economics are a reality. Whether you're a not-for-profit or a for-profit provider, you have to be able to cover your costs. The costs of spiraling in all categories. So in answer to your question, there are real cases out there where people think they should be getting 8, 10, 12 hours of home care, and it's just not affordable to the provider. They can't justify it and be able to afford to offer the program. So it's a difficult balance. It sometimes involves people moving to higher levels of care than they want to. But it used to be in the state that there were a lot of home care hours given, so somebody could get 2 12-hour shifts and get 24-hour care. It's much harder to get that now. It's harder because the costs and the responsibility for those costs are moving from government programs to providers who are capitated in a lot of cases, and they have to figure out a way to do it affordably. So it's a delicate balance, and it's probably handled very differently within different organizations in terms of their core values and so forth, in terms of how much care they can afford to give or not give. But it's a real question. The answer to your question, I think, yes. It's going on throughout the state, going on through the country all the time. It's a delicate negotiation to say to somebody, you've had 8 hours of home care a day. We think you can get by with 4 and doing other things to help them to do it. But to a person who's used to getting that and having that friendly face in their house helping them for 8 hours, it's a tremendous loss to say you're going to half their home care hours. So yes, I believe, and answer your question, it is out there and it's being dealt with on a day-to-day basis, and it's going to take more government involvement to get it to the right place.
I think what is good again about New York City and New York is that you do have a lot of access and options. So there isn't 1 or 2 home care agencies. There's a lot of home care agencies. And really, to address that question, I don't know what happened with that specific case or the company. Really, you shouldn't be able to deny any cases that are really appropriate for care under Medicaid and Medicare. So we really have to fulfill our mission anyone who's like for a nonprofit has to really get that. I think it's important that, eventually those cases are coming from other facilities, whether it's a doc or a hospital, and most home care, I'd say probably about 70-80% of it is coming from the hospitals. Hospitals are not going to tolerate a company that continuously denies or doesn't allow their patients to be serviced. There are other options. So the market, I think, and the demand will go to the other companies that are providing that care. I agree with David that under managed long-term care and even under fee-for-service, there are protections. So there's areas where you can make DOH complaints, and under managed long-term care, whether it's the hours or not the hours, there's a grievance process, there's an appeals process, there's a fair hearings process. To me, I think there's probably actually more venues and more areas on the managed long-term care side because we're obligated to provide those notifications. So they have to receive them within those time limits. We're monitored by the state and the federal government for all of our grievances and reports. So I think there are some protections there.
I would just add that there are, as in nursing homes, in-home care, there's a lot of information out there now for the public that wasn't out there before, to go online or to go to do a little research on to see where agencies are scoring well or not scoring well. Much like when you go to a restaurant in New York City these days, there's an A, B, and C in the window. They don't have A, Bs, and Cs for us, but they do score us on different things. Whether we've given flu shots, whether we provide adequate care, these things are certainly posted in the nursing home walls when you walk in. There's room for a more educated consumer now to understand and to pick your provider. It does differ greatly. I don't know about the specific incidents either that you mentioned, but care does differ from organization to organization. And I think it's in everybody's best interest to do a little homework before you choose who you work with.
Right. Now, I wanted to kind of, in wake of our transportation panel that we just had, I thought maybe we could kind of dovetail the two topics a little bit. There was a study conducted by the Children's Health Fund that cited a statistic that showed that 4% of children nationwide miss a healthcare appointment each year because of lack of access to transportation in the city. And I'm sure the same can be said for senior populations as well. Now, with so many public transportation deserts, so to speak, in New York City, especially in the outer boroughs, I mean, how can this problem be remedied of access to transportation to get to doctor's appointments or the hospital or community health centers of that and stuff like that? Anybody want to take that up?
Well, it's an interesting question. I mean, for people on Medicaid, Medicaid can pay for transportation, but even if someone's available to pay for it, it can be difficult to arrange accessoride pickups and whatnot. I think we're fortunate in New York City that for people who are physically able to use mass transit, we've got I think we have the best mass transit system in the world for all of the complaints we have about it, which are fully justified, but it's there 24/7. As long as you can figure out the signs and the announcements. Don't get me started. But I think that's probably a question better directed to the other panel.
Well, I would start off by generally saying that even in boroughs where they're not so far away, where they're not so distantly removed, if you talk to seniors, and I can only talk to seniors, I don't work with children, it's always on the top of the list of things identified as things that are frustrating to them. Accessoride and a lot of good programs that are out there, the volume of people that want these kinds of services, the amount of patience it takes to access them, cold weather days where they're waiting, getting back and forth to places, it's a regular challenge for people to get to senior centers, to get to neighborhood, I work closely with the Council of Senior Centers and Services. These are invaluable institutions for people to get to, but getting to them often is quite a challenge. So I think transportation really is never something we'll fully satisfy. I think it's something that always has to stay on the list of things that it's being worked on, because it's critically important to be that linkage. If you're isolated in a home setting and that's your vehicle to get to something, it's critically important you get there, not just to a doctor's appointment, to get to a senior center, to get to an adult daycare center site, to get somewhere where you can shop. These are critically important quality of life issues, and I think it's an issue that will constantly be a target for improvement.
On the first topic of transportation, I think it really is important. I think it's something that we do need to improve in New York State. So even though we have the best transportation system, I think, taking care of the vulnerable adults and seniors, even on the Medicaid side and offering transportation, we could do better. I think some of the suggestions of the other panelists were really good, and about the new taxi cabs that are, fit and really have access and take into account the elderly or the frail population is something that needs to be done. The other part of your question regarding babies and children, our organization has this program that we run, Nurse Family Partnership, and it really does help in trying to get new mothers and kids to really get prenatal care, help them throughout that initial stage, and then after that, really guide them and support them. I don't think transportation is the only thing that doesn't get kids or pediatrics to the physician and to the doctors. There's a whole host of things, and I believe having, again, that sort of advocacy and someone to help these people, and I would put them in the vulnerable population, pediatrics and infants, because they can't speak for themselves, and because of mothers who really don't have the family support that they need, or just the foundations where people can help them out. Those are the real reasons why, if the mother has to work and doesn't have somebody to cover, they're not going to take that time off and take them. So there are a lot of other issues that are involved in that.
I want to shift gears and talk about the expanding homeless population. Another kind of focus of the new mayor and the new administration. Coupled with the rise in homelessness, obviously comes a serious need for access to vital mental health care services, I should say. Does the city have the capacity to deliver psychiatric care? And is there kind of an inventory being done? Is there any means to do kind of an inventory of the mental health needs of such a rapidly growing population with that kind of by nature lives in the shadows of the city? Anybody can hop in on this.
Well, the mental health side of the world is not, is in the in terms of the assembly, is in the jurisdiction of our mental health committee, but there is certainly an effort to try to integrate all of care, which leads to what we are developing in New York is programs that the Affordable Care Act calls health homes, which has nothing to do with where you live, but are, and I don't know why they chose to call the program that, but it is essentially integrated networks of healthcare providers, a concept that ultimately ought to be available to all of us, but is being started out with many people with disabilities, with people with serious mental illness. And I think it's being started out there partly because if we can improve the coordination and integration of their care, there is a lot of room for improvement and for savings. I think that kind of development to help make sure that people are not lost in the system and that people get the care that what people's needs are get identified, and that the follow-up to get them to those services is identified. I think that will get us a long way to what you're getting at, and ultimately, hopefully quicker than ultimately, I think is the kind of model that ought to be available to all of us.
I think I'll, take this one on. I agree that, health homes are a vehicle, and, they're being built and they're being designed right now and trying to coordinate a lot of these providers. And as the years goes on, they will build the systems, they will get better at it, but right now they're in the sort of learning phase. What I see is that almost that there's a grouping together where there won't be real true managed care and real true providers. Somewhere there's going to be something in the middle. And there's going to be a melding of those two things where you're going to see a blend of sort of the insurance model and the provider community model come together, where you sort of learn the best attributes of each of the models. So whereas the health homes have the expertise of being in the community and developing those community resources, the managed care companies have the enrollment, the eligibility, the whole health risk assessment, quality, metrics, and all those goals. So I think both of them together will basically help each other out. On the area of mental health, I think the state is trying to wrap its arms around it, and they're trying to form new sort of plans. One of the ideas that's coming out is something called the HARP, which is really for a managed care plan for the mentally ill and trying to get them. They're trying to use them in the vehicle of managed care or the special needs population, who sort of have that expertise in special populations. Honestly, I don't think anybody does it well right now. I think there's a lot of work that needs to be done. There's enormous fragmentation. There's enormous access to care, where getting into a psychiatrist or substance abuse, getting the right care there really is not the best that we could do. So I think there is room for improvement there that hopefully will be taken into account with the new monies that are coming in. Right.
I wanted to actually put you on the spot, Dick, if you don't mind. You have long advocated for New York to have a medical marijuana program, and the governor has recently shown that he's been somewhat supportive of the program. I guess he would want it to be very tightly regulated and not kind of the free-for-all that it is in states like California. But I'm curious if this, if there's areas that, in the program, if it's too tightly regulated, that it won't be delivered to the patients, such as seniors or even children. I guess it can help some children with epilepsy and things of that sort. If it's too tightly regulated, will they have the access to to the program?
Well, actually, the bill that I'm sponsoring in the legislature with Senator Diane Savino is a very tightly regulated model. It is very similar to what the state of Colorado is doing and other states with their medical program. In Colorado, they use the slogan, regulations seed to sale. And so we've kind of adopted that slogan. The issue isn't, a very tightly regulated system, and what we're proposing would actually be more tightly regulated than the laws governing access to things like morphine and codeine and hydrocodone and Valium. It's almost embarrassing to someone with my political roots to be supporting such a restrictive piece of legislation. But what the governor has advanced is implementing or activating a law that was enacted in 1980 in New York and has has really never been used, that would allow access to medical marijuana through a hospital, and the hospital would have to have a review committee that would approve each patient, which I think is an extremely cumbersome mechanism. But the 1980 law is rooted in, requires that the availability to marijuana be done through a clinical research program approved by the National Institute on Drug Abuse. And clinical research is extremely expensive, extremely complicated and time-consuming. There is no money in the state budget for a clinical research program. And the other problem with the governor's proposal is that the only source for the marijuana in the 1980 law is marijuana either seized by law enforcement or acquired from the federal government's farm down in Mississippi, where they grow marijuana for research purposes. The problem with that, assuming we can adequately test the law enforcement marijuana, make sure it's clean, is that the only product that would be made available is sort of conventional garden variety dried leaf. Now, for some people, that provides the clinical benefit they need. For a vast number of patients with a variety of different conditions, different strains of marijuana have been developed in different states with very different combinations of which cannabinoids are in the plant. And some of them work very well for some patients. Some of them don't work at all for other patients. None of that would be available under the very limited program that Governor Cuomo was talking about. The governor's staff has said, kind of semi-privately, that if the legislature were to pass the bill that Senator Savino and I are sponsoring, he would consider signing it. Now, I've said that's very nice of him, but I think the Constitution says that if we pass a bill, he has to consider signing it. But what we've been trying to do is get the governor to say that he wants to work with the legislature to pass a really comprehensive and workable bill. I think if he does that, our bill would go through the legislature very quickly. Senator Savino estimates, and I think she's right, that of the 63 state senators, there are now about 40 that would vote for the bill, which no matter how you count the majority in the Senate, that passes the bill. The issue has been that the Senate Republican leadership has not wanted to move it to the floor. One of the arguments they give is, why should we stick our necks out on a bill that the governor may not sign? And so if the governor were to say, yeah, let's do the Compassionate Care Act, it would happen.
David, is there an issue with? It seems like it's kind of a cumbersome screening process. So, with some seniors who might want access to this program, what are some of the
I can't help you between the different versions and makeups of the product, but I can tell you that if you work in the field, which I have for 28 years, and care for people in all settings, nursing home, home care, otherwise, and you see them dealing with pain that could be made better by utilizing medical marijuana, you'd be hard-pressed to find anybody in our organization to be against it. Done properly, done well, properly, we're without a tool in our belt right now to deal with something, and it's anecdotally, everybody in this room has been touched by somebody who's been sick, and if you think there's something that can make that pain lessen, and it's available to us, and it's going out on everywhere, I think you'd find we'd be wholeheartedly supportive and anxious to be able to use it to help people to feel better.
Dr. Abdul, do you have any
I think
on this?
I agree with David and the panel that, when it comes to utilizing marijuana for treatments and getting the necessary medications, what we're looking at for comparisons of here's what docs have available for them. You go first to Tylenol. Tylenol doesn't work. You go to Advil. Advil causes high blood pressure, renal impairment, a whole bunch of other side effects that you don't want to do. Your next step is then stepping up to the hydrocodone, the morphines of the world. So when you're comparing those drugs to medical marijuana, some of those things really you might have to consider that this might be the better option for a lot more people. The other drugs have unbelievable side effects, a lot of complications caused by them, especially in the elderly. So yes, I think I'd be in favor of utilizing that for medical treatment.
Now we want to. I'm sure there are a lot of people in the audience who have questions for our panel of experts here. So I want to open it up. Anybody who's interested in asking a question.
Shelley Winfield, that was really a great question. Thank you, Shelley Winfield. That was a great question you asked about the need for transportation for children to get to their clinic appointments. And I've made this announcement everywhere I can imagine, but I'd like to share it with you. That at Bellevue Hospital Community Advisory Board, we found there was a problem getting the children to their clinic appointments because a parent was asked to pay for a child because there was a sign on the bus that said after 44 inches, they have to pay full fare. That's age 4. And we do at Bellevue Hospital provide a full MetroCard round trip for them to bring their children to the clinic, Medicaid parents. But age 6 and older. So I share with you and everyone in the room, because if you know the problem, we can all roll up our sleeves to solve that problem. There's a gap. We'd like you to make those suggestions so we can move forward. The Transportation Council has already assisted us with a letter to MTA, but we need everyone's help. Thank you.
Hi, my name is April Moore, and I have 2 questions. One is related to the initiative to save costs with.
Could you speak more directly into the mic?
Oh, hi. My first question is related to the initiative to save money related to emergency room admissions. And well, first I would like to say that healthcare policies aimed at cost saving disproportionately affect populations with lower incomes due to their reliance on public health care or private healthcare programs that do not have a 5-star rating. So the risk associated with asking a parent or a caretaker to assess the gravity or be restricted to a healthcare facility in their community is too great. So my question is, what is wrong with the model that most hospitals use that fast-track patients to urgent care divisions within the hospital or forward them to full emergency services after a triage assessment?
So
I have another question.
I'm sorry, so you're asking
Oh, listen.
about hospital triage that shifts
Because
children
there's
either
an issue with the movement is to save costs with healthcare, and they want parents or people or individuals who receive healthcare through HMOs or public Medicaid, programs.
Yeah.
They want them to take their child or loved one to urgent care or community-based program that may not have the facilities to treat an issue that was assessed to be non-threatening, but they go to that facility and now is a critical issue. So there's hospitals like Mount Sinai and St. Luke's that have an urgent care. So a professional within the realm of a facility that is equipped to have to address an emergency situation can assess and forward them to a fast track, which is cost saving, or if the situation is warranted, forward them to the emergency care division. What's wrong with that model that's already in place?
Okay. Well, I think the urgent care concept, and those words get used in a lot of different ways. People nowadays, many people think when they hear urgent care, they think the storefront on 69th and Amsterdam that says urgent care, which is basically a doctor's office. An excellent place, by the way. They do very good work. There are also hospitals that have a separate part of what might have been their emergency department that is now called urgent care for things that really don't need all of the equipment and whatnot of the emergency room. I think getting as many people out of an emergency room into something appropriate when that is appropriate is better for the patient. It's probably going to get them care quicker. It's going to save money and resources so that those resources can be used for people with heart attacks, what have you, who really need the emergency room. I believe that if programs like that are made available to people and are easily accessible, and the patients are given the information so that a parent can know that if it's an earache, you can go to the urgent care place. If it's if your kid's finger got cut off, get them to the emergency room and don't mix that up. Parents can handle that level of decision making and a lot more than that. It's a question of letting people, of making that service available and letting people know that it's available. You'd also want to make sure that if somebody doesn't know and takes their kid to the emergency room, I would hope that nobody ever tells a parent who arrives at an emergency room in the middle of the night with a child with an earache, sorry, you've come to the wrong place. That would be a terrible thing to do to a child with an earache. So if done thoughtfully and well, I think it can be an improvement for everybody.
I just want to go off point for a second. You know, when we're talking about vulnerable populations, I feel, and I know time is getting short, so I didn't want to let time go by without mentioning the work that we're doing at the Hebrew Home and now in partnering with VNS to deal with issues of elder abuse. Elder abuse is perhaps where child abuse was many years ago. It's not often realized, it's not often reported. It often goes on in family environments where people don't see it. We have actually made a commitment at the Hebrew Home. Our director, Joy Solomon, is here 10 years ago to create a shelter for elder abuse victims within the facility. But the work is much more to be done, and working with VNS, working with the Council of Senior Centers, and working with everybody in this room to improve the education and awareness of this epidemic, I think is an important thing to think about when you're dealing with a population like this.
Good.
Hi, Beth Finkel from AARP. I know you touched on home care. I wanted to just bring more attention to the family caregiver. In New York State, family caregivers provide $32 billion worth of services for their family members, and that's about 4 million New Yorkers are actually providing that service. We recently did a survey here in New York City of 50-plus voters and found that over 60% of those family caregivers were feeling an inordinate amount of strain, to the point that at a certain point they might have to look at other options, including institutional care. We know that 9 out of 10 Americans want to age in place with their own families and communities, and I know many of you, especially David, really provide great services for that too, and the Council of Senior Centers and Services, but more needs to be put in place for those family caregivers, so that families can stay together, so that people get the services that they need, and so it doesn't put more of a stress and strain on our Medicaid budgets, because ultimately when we hit this aging tsunami and more people are in that age group, it's going to be an overwhelming burden to our resources. So now is the time to really look at how we can get more resources in place. I wondered your thoughts on that. Thank you.
So I agree with you. I think caregiver burnout is probably, one of the key reasons why people are going into nursing homes, and it's been one of those things that really, when the family gives up or is too tired or they can't handle it, because they're sort of the sandwich generation. They've got the kids to take care of, they've got their jobs, and then they have their parents or their grandparents that they're taking care of. Again, I'd have to applaud New York, because New York has been on the forefront of developing programs that really try and support that. So we started out here with the Lombardi program 25 to 30 years ago, which is the long-term home health care program, which really took long-term care and put it into a new vision. And that graduated into managed long-term care, and then there's other areas where we could help out. When in New York, people are really being assessed for that kind of care, they've got to take the whole dynamics of the family. So, one of the mainstays of the assessments that happen has to happen in the home or in the environment that they're in order to see what's going on. The assessments that are done usually take more than 2 hours on initial assessment. Not only that, because of the vulnerable population, we really try and get family members and caregivers and neighbors involved in the whole process to sort of address and assess that. I think more could be done. I think it's an issue that's going to increase, and as costs are driven down, because everybody's feeling the cost. I mean, there isn't a provider in healthcare that's not getting pressured into decreasing their cost of doing care. And that's basically the ask of, the federal government and the state government and our public policy. We have to do more with less. How do we do it and make sure that we achieve the same quality, the same satisfaction that we get that is the holy grail, I would say. I think it's going to be turbulent while we go through all these changes, and providers and managed care organizations are figuring out what to do in this new world, and who am I, who do I act like, because it's not traditional anymore. Nursing homes are transitioning into what they're going to be for the future. The care that nursing homes or home care is doing is not the care that was done 15, 20 years ago. I mean, I usually go around and say, as an example, just to show you, 20 years ago, a newly diabetic that was just found to be diagnosed was put into the hospital until they were controlled for 6 weeks on insulin. That's the past. Today, we've got hospital lengths of stays down to 5, 4, and 3 days, and people with bypass surgeries are coming out after 3 to 4 days. So I think we'll get there.
I would just add, first of all, thank you for the question, because there's never going to be enough attention on the caregiver. You can't have an adequate care plan without a caregiver, and unless there's support for that caregiver, none of it works. So whether it's support groups, resources, training, daycare sites for respite, there can be never enough. That's a very difficult role, and with the things we talked about with reductions in home care hours and things that costs are driving down, more important than ever that that caregiver get the support they need to be that caregiver. Otherwise, we graduate to more extensive levels of care than perhaps is necessary.
I think we have time for one more question, and
Great,
we'll wrap it
thanks.
up.
Hi, Assemblyman Gottfried. As the chair of the Health Committee, you've done a lot of great work with addressing radon in the kitchens here in New York, and I wondered if you could talk to everybody here about what's being done about radon in kitchen gas that's coming in from the new forms of natural gas coming into New York.
Okay. Well, just some background. I'll try to do this quickly. Until now, nobody's had to worry that your stove was pumping out radon. Pardon me. And that's mostly because the gas we use comes from far away. By the time it gets to us, the radon has gone through its half-life and several times and is not anything to worry about. If we are going to start getting cooking gas from New York State and Pennsylvania through hydrofracking, it's going to get into our stoves really quickly and will have fairly active and dangerous levels of radon in it. My colleague Linda Rosenthal, assembly member from the Upper West Side, has drafted a superb bill that would have the state set limits on allowable levels of radon and provide for 24/7 monitoring in the pipelines, et cetera. I mean, we'd be a whole lot better off, in my view, if we weren't looking at doing hydrofracking in New York and weren't doing it in Pennsylvania. But the radon side of that issue, I think, is really important. And I think if more people knew about the radon potential, well, the radon reality in the gas that's coming from Pennsylvania and might come from upstate New York, I think there would be a lot more opposition to allowing that kind of drilling.
All right. I'd like to thank our panel for joining us today, and thank you to the audience.